Okay, I will start in Arabic. Welcome. السادة الحضور جميعا، السادة عمداء الكليات، الأساتذة المحترمون، طلبتنا الأعزاء من مختلف كليات العراق، نرحب بكم اليوم في هذه الندوة. إن شاء الله راح يلقيها البروفيسور نايجل والبروفيسور ديبرا. We will start now to introduce Prof. Nigel. Prof. Nigel and Prof.Deborah, an Emeritus Prof in University of Sheffield Teaching Hospital. They are an expert in medical education and they have a long history in this field. And today they will talk about how to have an excellent doctor for Iraq. And the topics we'll cover in this webinar will be the role of doctor, what attributes should a doctor have, how should medical students be selected and why, how to be successful and avoid failure, and finally the medical challenge you are facing today in COVID-19 teaching, learning, and being an intern. So the Zoom is yours, Prof. Nigel, so please you can start.
Thank you. Yeah. Hello, everybody. It's very nice to be with you. We're just going to get rid of us all and excellent. So it really is a huge pleasure and an honor for us to be with you all today. Students from all the medical colleges in Iraq participating. Excuse me. So thank you very much, all of you, for joining this webinar, which is going to be a lot of fun. Thank you to Professor Hussam Hamid from Wasit University, College of Medicine, for having invited us to deliver this webinar for medical students, and also to his colleagues, Dr. Nasser, Dr. Mahood, and Dr. Khalid, also from Wasit, who have been of tremendous help to us. Now, we've had the great pleasure of working with doctors and students in more than 20 of Iraq's medical colleges over the last 11 years, and we've learned a great deal from you, so thank you very much. We know how famous Iraq is for having produced outstandingly good doctors over many years. And the last 20, 30, 40 years, they've been very, very challenging for you, very difficult. And the purpose of this webinar is to discuss how Iraq might re-establish its previous leading role in medicine and in medical education and training. So what we'd like to do is to consider how Iraq is going to produce excellent doctors. What is the role of a doctor is one thing we're going to discuss, and we're going to ask you some questions about this. What attributes, what characteristics should a doctor have? And how should you, as medical students, be selected? And why? How can you be successful and avoid failure? And we have two pieces of advice. And then finally, we want to deal with some of the big medical challenges that you're facing today in Iraq. Obviously COVID-19, but teaching, learning, and also being an intern. Being an intern is a big challenge. Now, we come from the UK, and in the UK we have worked in Sheffield, and that's where Sheffield is, right in the centre of the UK. And we've worked at the University of Sheffield and the university hospitals in Sheffield for many, many years. Our students, and this is some of them, look pretty much like you. There's no difference. In our university, we have 29,000 students, and they come from 140 different countries around the world. And the university has 1,200 academic faculty. But as you can see, these people in the photograph standing outside the medical school in Sheffield, they could be standing outside a medical school in Iraq. You look just the same. Now, all of you want to become a doctor, and we'd like to ask you a question about this. What will your role as a doctor be in the future? And what we'd like you to do is just to think for a minute about this question. What is it that you're going to be doing? How will you work? What will be your responsibilities? Write your thoughts down on that piece of paper you've got, and then we'll show you what we think should be the answer. And we'll give you a minute. So 60 seconds has started. Just have a think. We know that we can't see your answers, but we believe that you'll be writing things down. Keep the things that you're writing down and start to share them with each other when you can. That might actually have an influence within your medical school, medical college in the future. So you've got 20 seconds to go. Okay, let's show you what we think the role of a doctor is, and let's see how close what we think matches up with what you've written down. That a doctor is somebody who has the ultimate responsibility. They are absolutely at the top of the pile for taking difficult decisions in situations of great medical complexity and uncertainty, drawing on scientific knowledge and clinical judgment. And this definition was made by the Medical Schools Council in the UK 12 years ago. We don't think there's a better definition of what a doctor should be doing. But you can translate that into, by graduation, you must be able to take responsibility, take difficult decisions, deal with complex situations, cope with uncertainty, and that includes an understanding of knowing when you have to ask for help, using your knowledge, and making clinical judgments. Now, being able to do all of these things is not easy. What sort of person is able to do all these sorts of things? That's a big list, a big ask. So here's another question for you. What's the sort of person who can do all these things? What attributes or characteristics should a doctor have? Again, just think for a minute about this question, and then think of the 5 most important attributes that a doctor should have. Again, we can't see what you're writing, but you might want to share what you've written with other people and your colleges in due course. So we'll give you 1 minute to think about that. So we hope you're scribbling away, thinking hard, coming up with some important attributes. If anyone's written making money, leave the webinar immediately. So we wonder what you've put down. This is what 250 medical students in the first year at their course at the University of Sheffield said were important attributes. Top, good communication skills. Next, honesty. Then approachability, empathy, being able to feel with other people. being patient, not being prejudiced, having confidence in what you do, being able to work as part of a team, being able to care for other people, and having respect of other people. And we asked the same question to 300 medical students at the Baghdad College of Medicine a few years ago, and this is what they said. My goodness, it's almost exactly the same. So wherever you go, actually medical students think that doctors ought to have virtually the same characteristics. But look at the top two: good communication skills and honesty. Now, of course, all of these are characteristics that will develop well before you enter medical school. Here is a marvelous leopard, and the spots on this leopard never change. And as humans, we don't change much from what we're like when we're aged 17 or 18. What we're like at the age of 40 or 50 is actually very similar to what we're like when we're 17 or 18. What you're like at 17 or 18 is usually what a person is going to be like for life. So, if somebody has difficulty communicating with others when aged 18, it's very likely that they will have difficulties communicating with others throughout their life. Someone who is dishonest at 18 will probably be so later on in life. Which leads us to consider, how should we choose people to come into medical school? Now, in Iraq, selection to medical school is based on high school examination mark. In other countries, other things are taken into consideration. You have to have a high mark from high schools, but also you have to show that you can communicate, that you're reliable, you show empathy, you can think and reason, you can engage in decision analysis, which is all about how one makes choices. And in medicine, this could be how best to treat a patient. And in medical education, this could be about how to design a curriculum. And a situational judgment test, which is all about a person's values and behaviors and how they influence that person's actions. Now, all of these are what are known as non-cognitive assessments. In other words, you don't need knowledge to be able to undertake communication or reliability or empathy. You can't revise communication skills. You've either got it or you haven't got it. So, in many countries, Australia, Canada, the Netherlands, the United Kingdom, medical schools have introduced a selection method of medical students called the multiple mini interview. And candidates are assessed on their ability to communicate, how reliable they are, whether they can show empathy, whether they understand autonomy, which is all about a person having the right to determine what happens to them. For example, a patient might decide that they don't wish to have a treatment that you have recommended, and you have to respect that decision. Can the student make decisions? Are they honest? Do they understand the need for confidentiality in medicine? And a candidate would start at one station. This is rather like an OSCE. They'd start at one station, and they would then go through all these stations, and each station would last between 5 and 10 minutes. At one station, they might be given a task like this. They get a piece of paper which says, "You've just driven a car over your neighbour's cat and killed it. The neighbour is in the next room, and we want you to go in and see the neighbour and explain what has happened." Now, what is this testing? Obviously, it's testing communication, but also a prospective medical student would be expected to show empathy and to be honest. This is unlike one candidate who said when they went in to see the neighbour, "I've got some bad news for you. "My father has just killed your cat." Now, we all have failures in life. Usually, these are quite small, and we learn from them. And mainly, we're able to go down the road to success. Here are some young doctors just about to start work as interns. Almost all will be successful, but some will not be. Why are some not successful? What are the main causes of failure as a doctor? Well, let's go back to the multi-mini interview. What this is assessing is a candidate's personal values and behaviors. This is very important. Remember, the leopard does not change its spots. The values and behaviors one has when entering medical college will become those that are with one for life, and they will be one's professional behaviors as a doctor. And it's one's professional behaviors and clinical ability, that's knowledge, skills, and experience, that together make one a doctor. And there are two major reasons why a doctor's career fails. They can't communicate, and they're not honest. These, of course, are the two characteristics that medical students recognize as being the most important features of doctors. Let's go back to that list again of what you must be able to do by graduation. And let's just take one of these areas, and that's dealing with complex situations. Because medicine, as you all know, is full of complex situations. So let's ask you all now to do a situational judgment test. Don't worry, you're not going to get marks. There's no passing, there's no failing. Actually, this is a good learning experience, and we'll show you. So, you're seeing a 58-year-old woman in the emergency department who tells you that she is feeling exhausted. She developed a sore throat a week ago, and over the last 3 days has been coughing, producing green sputum. She's had some shivering attacks and has been sweating a great deal. So, it seems this lady has a chest infection, possibly pneumonia. That's all you know so far. What are you going to do next? What will you do first? And what we would like you to do is to choose one of these options. I'll give you a few moments just to look at them. Okay, so ask her husband about her illness. Well, that wouldn't really be appropriate at this stage because the woman can talk herself. Something about autonomy here. She must be able to make her own decisions. Examine the chest. Well, you might do that. Perform a chest x-ray. Well, certainly not before you've examined her. Start treatment with an antimicrobial drug. Well, you wouldn't do that before you've examined her and maybe investigated her. You would take more history from the patient. That is the correct answer. So this is asking you not a knowledge-based test, but actually, what would you do? How would you behave in this situation? So you take more history. Now, she's been well until about a year ago, when she started to have some difficulty swallowing, and over the last 6 months noticed that her voice has changed and become more nasal. That's rather like that. Pinch your nose, that's a nasal voice. So her voice has become nasal. And she hasn't seen a doctor about this. Now, you need some knowledge and a bit of experience here, although it is a situation that a final year medical student should be able to deal with. Here we have a patient with a chest infection, difficulty swallowing, a change in her voice that suggests her nasopharynx may not be working properly. So, what one aspect of physical examination will help you make the diagnosis? And here are the options. Have a look at them for just a moment. Okay, well, let's start from the bottom. Would you test her sense of smell? Well, there's nothing really to suggest that she's lost her sense of smell. Would you test the plantar responses? Well, there's nothing in the history to suggest that she has any pyramidal tract symptoms. Testing the gag reflex? Well, that might be a possibility because she's got a difficulty swallowing. Testing hearing? Well, she's got no hearing loss. Inspection of the tongue? Well, that, of course, is the correct answer because what you're looking for is whether or not the tongue is fasciculating. That means just twitching, the small muscles in the tongue twitching away. So you look at her, and the tongue is very thin and it's twitching. And you show this clinical feature to another doctor, and you suspect that the underlying diagnosis is motor neuron disease. Now, her husband is very anxious. He's watching you carefully, and he asks you, why have you inspected the tongue, and what's the problem? What are you going to say to him? And you've got to choose one of the following 5 options. I'll give you a bit longer to look at this one. Bit of a challenge, this one, isn't it? It's more difficult. So, I always look at the patient's tongue. Well, that's not answering the question the husband has asked you. I'll get someone else to come and talk to you. That's not taking responsibility yourself. Go to number 4. Please do not interrupt me at the moment. That's just rude. That's poor communication, poor empathy. Or, I think your wife has motor neuron disease. Well, that's not really appropriate at this stage. You've not had a specialist opinion. There are no investigations that have been done. And in any case, the first person to hear of the diagnosis should be the patient, not the husband. So the correct answer is, I wanted to check how well your wife can swallow. But notice it doesn't actually answer all of his questions, which is, what's the problem? So that's the best answer of those 5. Now, why are these tests so important? They're important because they're one of the few tests that will predict your future performance as doctors. All the other examinations that medical students take, not just in Iraq but around the world, on the whole do not predict future performance. But situational judgment tests do. So, to get good performance, you don't just need good students, which you all must be, but you need good tutors. So what are the features of a good tutor? And this is the third question we'd like to ask you. This is the last question of this format. Just think for a minute. What are the features of a good tutor? Think of the 5 most important features that a good tutor has. And then we'll show you the evidence. What we would like you to do is to share what you have written with your medical colleges. So you've got a minute. Off you go. 5 important features of a good tutor. I hope you're scribbling away. So 20 seconds to go. There are no wrong answers here. Anything you put down will be very helpful. So, what are the features? And these are data from 20 years ago, but they are very, very appropriate for today as well. A good tutor is enthusiastic. They enjoy teaching. They're competent at teaching and usually have been trained to teach. They're an expert in their subject. They have good relationships with you and with patients. And these are genuinely good relationships. They're not trying to upset you or upset patients. They create the right environment. They don't bully. They don't shout. They're just nice people who are there to support the development of students. They use a variety of teaching methods, and they're available, not just in lectures or in seminars, but outside that time, so that you can go and talk to them about your bits of misunderstanding or lack of knowledge in one area, and they will advise you. But they have two other features as well. They're excellent role models. They're people that you would like to copy because they're so good at what they do. And also, they provide feedback which is constructive, helpful, timely, and allows you to develop as well as possible. There's something else. Teaching helps you learn. Teaching is one of the most powerful ways that helps people learn. Therefore, you must learn how to teach and then teach. And colleges, it would be wonderful if they could find opportunities for you to teach other people within the college or even within other colleges. Fantastically powerful way of learning. Now, why is it so important that you become an excellent doctor? Well, Iraq faces a number of medical challenges at the moment. And some of these challenges are common around the world. This, of course, is the obvious one, COVID-19, and this is the beast in close-up as seen by electron microscopy. The virus has caused a global shutdown in education. The countries shown in purple have had a complete shutdown of schools and universities, and this has affected 158 countries. Overall, 70% of all school children and university students have been affected. The virus has caused disruption and chaos. In medical colleges, lecture theatres have gone from this to this. Lecture theatres are now empty. Lectures are delivered online. Teaching ward rounds with medical students, and you can see the students on the right of this picture in their clean white coats, have gone from this to this. The absence of clinical teaching and learning is causing particular difficulty in all countries, not just Iraq. In the UK, clinical teaching has just restarted in very small amounts, but with frequent COVID testing of students and students wearing PPE. Here's another challenge. The population of Iraq today is about 40 million. It's predicted that by 2040, it will have increased by 20 million, and by 2060, it will have increased by another 20 million. And by 2080, it will be almost 100 million. That is an overall increase of 140%. That is a massive increase. It will have a huge impact on health services and on medical education. If we look at predictions for population increase in those aged 60 and over, we find in the next 20 years, the increase will be about 250%. And that's when you are going to be particularly important in medicine in Iraq. This will rise to over 500% by 2060 and over 800% by 2080. Now, it's the people aged over 60 who have the greatest healthcare needs, and these data show that there is a developing healthcare crisis in Iraq. How might Iraq respond? What can medical colleges do? Now, you may have very good ideas about this, and we have some suggestions that we'd like to make later in the seminar. A further current medical challenge in Iraq is the low number of doctors compared with other countries in the region. Iraq has about 0.7 of a doctor per 1,000 of the population. Let's look at the number of nurses. Please note, though, that the scale is different compared with doctors. There are about 2 nurses per 1,000 of the population. For an effective health service, one needs at least 2.5 doctors per 1,000 and 3 times as many nurses as doctors. Now, the final medical challenge we would like to mention relates to premature death within Iraq and prolonged disability that stops someone from working. You'll notice at the bottom of this slide it says disability adjusted life year. So what is a disability adjusted life year? It's a year lost because of premature death. So if someone dies at the age of 50 and was expected to go and live to 70, that's 20 years of life lost. And if you add up all the lives lost from premature death, and they are shown in green, together with the years lost because people aren't able to work because they are ill, that's the disability, and you put all of those together, you come up that every year 11 million disability adjusted life years are lost in Iraq in a population of 40 million. That is non-sustainable. That is just ghastly. Poor health and early death are dreadful by themselves, but they're having a massive and very large negative influence on the economy of the country. So good health makes the country work better. In summary, the challenges facing us all today, and medical colleges in particular, are massive changes in medical education, which have had to occur as a result of COVID. No longer can we learn directly from patients. We can't care for patients. There's a massive population increase about to occur. The numbers of doctors and nurses are too low. Premature death and lasting disabilities are having a huge impact, both at a personal level and at a national level. And COVID-19 just isn't going to go away. Before we joined you in this webinar, Deborah and I have been taking part in a 2-day meeting with people from all over Europe. And the prediction that we keep hearing from doctors all over Europe is that the COVID pandemic is going to go on for 4 or 5 years. And only then is it going to get low enough for allowing normal life to be resumed. Well, we think that is a very pessimistic view, and we think the science will help us out here. But COVID-19 is having massive effects. Now, this is the area of Iraq covered by the medical colleges attending this webinar. That's the area enclosed by the little black dots. And here are the 8 colleges shown in blue. The current population of this area is about 12.5 million. There are 72 public hospitals in the area, of which 20 are teaching hospitals. And overall, there are 12,700 hospital beds. And this provides about 1 bed per 1,000 of the population. There are 742 primary care centres. There's a lot of potential patients in this area who need you to care for them. Now, caring for patients requires a diagnosis to be made. And one key purpose of your learning, your teaching, and the experiences you're having is to enable you to make a diagnosis. The 2 key elements to make a diagnosis are taking a history and performing a physical examination. How important is history taking, and how important is physical examination in making a diagnosis? Well, work from many years ago showed that the history alone allowed the diagnosis to be made in 85% of patients. Physical examination was about 10 times less likely to enable a diagnosis to be made. Having made the diagnosis, then a management plan can be made, undertaking any required practical procedures and providing continuing support to allow one to care for a patient. So what in this COVID-19 era are you able to learn? Let's have a look. History taking can be achieved, and with real patients. Physical examination is more difficult, but not impossible, again with real patients. How to manage patients can most certainly be learned. Practical procedures can be learned in clinical skills laboratories with social distancing, and the continuing care and support of a patient can also be learned. How can this be done? Well, here is someone who is not feeling very well. And here, distant from them, is a medical student, could be you, and a doctor, their tutor. They can communicate with the patient using IT, possibly using a very small camera. Other students are able to watch the student and doctor take a history. And in addition to the history, you can undertake a basic examination, come up with a differential diagnosis, and work out an immediate plan for management. The patient could be in a hospital, you could be in the college, they could be in the hospital. They could be in a health centre, they could be in a pharmacy even. Now, students will learn by doing this in the best way possible. They will learn by doing. They'll be contributing to the care of patients, and this will allow you to develop a professional identity. The patients you see can be entered into a logbook, and the recording of the consultation can help create a library of clinical problems. Now, what a wonderful and extraordinarily valuable development it would be if colleges could work together and collaborate in this approach. Within each college, students would form small groups of 8 to 10. A consultation within one college or its associated hospitals or primary care centres could be made available to students in other colleges. The small study groups would have shared clinical experience, be able to discuss them, and thus develop reflective practice. To achieve this, there has to be collaboration between the colleges and a willingness to share learning opportunities. It would help students from all years of study to see all the core clinical conditions and, importantly, link clinical experience to the underpinning sciences. So this approach would be useful for years 1, 2, 3, 4, 5, and 6. We showed you this slide a few minutes ago. And we'd like you to look at the second and the third lines, cardiovascular diseases and diabetes, which are non-communicable diseases, and the other NCDs, the other non-communicable diseases. Now, they, between them, account for about 30% of all the DALYs, disability-adjusted life years, that are lost each year in Iraq. There are some major public health issues relating to this. 41% of adult Iraqis have a high blood pressure. 10% or more have diabetes. Many are overweight, some obese. Many smoke. And not connected to the NCDs are the low vaccination rates. How can these public health problems be linked to the medical curriculum? We would suggest that students undertake public health activities that will address some of the major causes of disease in Iraq. This would provide them with real clinical experience and be of real help to the citizens of Iraq. It would link your learning directly to clinical practice, a really powerful and important way to learn. So, you could run blood pressure testing in the community, provide urinalysis checking for diabetes. You could run clinics to help people stop smoking. And also, you could actually be trained to give vaccinations. That's quite a jump, but it's possible. And at the moment, Iraq has only got 0.7 of a doctor per 1,000 of the population. Now this year, 7 of the 8 colleges in the area will graduate 462 doctors. We apologize, we don't have data from the 8th college. Over the next 4 years, the number graduating is likely to double to about 1,000. And then in 2025, there should be about 1,700 graduates each year. Taking into account the likely population increase, there will then be, in 2050, about 2.5 doctors per 1,000 of the population, which is a good number. What do we need to know about these graduates? Now, many countries are asking the same question. There's an increasing and understandable view that all graduates in medicine should have the same abilities. Therefore, the question should be asked, do all graduates have the same abilities? And one way to start to address this issue is by colleges having shared and common questions in final examinations, so that interns are known to have broadly the same abilities and knowledge. How does one become an intern? Well, at present, the route to become an intern looks like this. A period of learning sciences is followed by clinical training, and then one becomes an intern. Or doesn't. An important problem in Iraq is that there may be a 6 to 12-month delay between the time of graduation and starting work as an intern, and this will result in graduates becoming de-skilled. It really would be ideal to get rid of this delay. An approach to the structure of the curriculum that is increasingly seen around the world is this. Teaching and learning in the sciences, which is in the red, continues throughout the entire undergraduate course and extends into the time when one is an intern. This is important because it helps keep everyone up to date with advances in scientific knowledge. The scientific knowledge needed to practice medicine is directly related to the clinical problems one sees. Therefore, early clinical contact and linking this to the science teaching is increasingly seen around the world. Interns are engaged in clinical practice, and many medical schools are introducing this during the undergraduate curriculum, and there is no better preparation for being an intern. One other thing that is happening in undergraduate education and postgraduate training is this. All aspects of both undergraduate education and intern training are linked together. And how an intern is trained links to how further training is structured. So, how are we going to make excellent doctors for the future? There are 6 important ways that we will achieve this. Firstly, learn by practicing medicine. So, getting students to help deliver the service is a key aspect. Become good at clinical reasoning. This isn't something that can be acquired easily. It requires careful mentoring and good role models in one's teachers. Practice the practical skills until one is able. This is undertaken through mastery assessments. Now, this is something you may not be familiar with, but let's take doing CPR, cardiopulmonary resuscitation. The first time you try and do it, you won't be able to do it correctly. Possibly the second time, and the third time, and the fourth time. But after you've practiced it enough times, you might be able to do CPR. So the first time you do an assessment, you might not do it adequately. You have another go a week or 2 later, and you keep on having that assessment until you show that you can do it properly. The pass mark for mastery assessments is not 50%. The pass mark at a mastery assessment is about 95% or more. You don't want someone who is 50% competent doing CPR on a family member or a friend. You want someone who is 100% competent doing that procedure. And talking of procedures brings us to patient safety. No clinical, practical procedure should be practiced and undertaken on a patient until it has been taught and assessed in simulation. Life in medicine is about making difficult judgments, and that's about situational judgment tests, which we talked about already. And the final thing is, we expect people to show commitment to patients. Increasingly, we're getting feedback from patients about student performance, and also multi-source feedback. So nurses, occupational therapists, physiotherapists, radiographers, nurses, everyone might contribute to a judgment being made about a particular student. That helps us know whether that student is going to be able to work as part of a team. So, one final situational judgment test. You're seeing a patient with your resident. The patient has pneumococcal pneumonia, and the resident is about to give an antibiotic intravenously and tells the patient that the drug is penicillin. Now, in this situation, we want you to imagine that you are just starting work as an intern. This is your first day on a ward as an intern. And the resident is someone who's a slightly more senior doctor, been around for a few years. The patient says, "I'm allergic to penicillin. Don't give it to me." And the resident says, "There's no record in your notes of being allergic to penicillin. Everything's going to be all right. Don't worry." And then the resident then starts to inject or prepare to inject the penicillin. What one of these four actions are you going to take? You check on the patient 2 hours later? Well, that won't be any good. If the patient's allergic to penicillin, they might be dead. Would you recommend that the clinical notes are checked? Well, you know that there's no record in the clinical notes about penicillin allergy. Would you recommend that an alternative drug is given? Possibly. The answer is you would stop the resident administering the drug. The message here is that you, as both a student and as an intern, have a responsibility. If you see potential harm occurring to a patient, you have to say, stop. Whoever it is who is doing whatever, you say, stop. Let's have a minute. Let's see what's what and try and sort it out. You stop. But the patient gets the penicillin, develops anaphylaxis, and they get resuscitated. The resident says to you, don't tell anyone that the patient had said they were allergic to penicillin, and says that in any case there was no record of any such allergy in their clinical notes. What are you going to do? Choose one of these. Tell the patient what had happened and why? Well, you might. That's going to be possibly helpful, but it isn't going to solve the problem of this resident's behavior. Agree to do what the resident has asked? No, that would be lying. Record the incident in the clinical notes? Yeah, you might do that, but actually what you would do is tell the resident to report the serious incident and tell them that if they don't, you will. That's taking responsibility. That's what you have to do. Now, the patient subsequently instructs a lawyer to sue the hospital for damages. And on checking the clinical notes, you see that the record has been made in the clinical notes by the resident wasn't true. It didn't actually describe what happened. And in particular, there was no reference made to the patient saying that they had a penicillin allergy. What are you now going to do? Tell the resident that an additional entry is made in the clinical notes? That's a complete waste of time. Obtain legal advice? Why? Offer your resignation? No. This is an example of you can't now cope with that situation. You need senior help. So you go and see the specialist for whom you work to discuss the matter. So this little scenario has been about stop, take responsibility, and know when to ask for help. And this is why situational judgment tests are incredibly powerful at predicting future performance. Every single one of you is essential for the people of Iraq. The Iraq people desperately need you and need your skill, your wisdom, and your help. And we wish you every success in your future careers. Your success will help restore Iraq to its leading position in medicine and medical education. So we say goodbye and good luck to you all. Thank you very much for listening.
Well, thank you very much. That was a really interesting talk. And I feel jealous because I didn't have a lecture like that when I was a student. So they're lucky for this informative and interesting lecture. Thank you very much, Prof. Nigel. What I think, maybe we'll start a session of Q&A. If anyone wants to ask a question directly, maybe just raise hand. I will make it a bonus and he could ask a question to Professor Nigel directly. So please just...
okay, we'll try and answer.
Yeah. May I... there is a Layla. I will make it a panelist to ask a question.
Dr. Nigel, by the way, I ask a question, please.
Yes, of course, please.
For the time, what's your opinion about the medical teachers can act as a simulator of patient?
Well, you could. It's not ideal for lots of reasons, because the relationship that you have with students is a very precious and special one. And if you start taking your clothes off with students and let them examine you and put their hands on you and all the rest of it, that will disturb the relationship that you're trying to develop with the students. So how about another idea? We had a problem about nearly 20 years ago, that we recognized that our students were not always seeing enough patients. They simply, the nature of the health service was changing. Patients were whizzing through hospitals so fast that they weren't able to spend enough time with patients to take their stories, to take their histories. And an example would be that when I was a student and when Deb was a student, a person who'd had a heart attack would be in hospital for 10 to 14 days. A person with a heart attack now is in hospital for 10 to 14 hours. They have their angiogram, they have their stent, and then they go home. And life has changed, but the students have to hear the story of what it's like to have a heart attack. So what we did was we started recruiting patients. We call them patients as volunteers. And we have about 1,000 of these patients now in Sheffield. And these are people who are happy to come in and talk to students and let the students examine them. But they're not attending clinics. They're not attending an outpatient clinic or coming to the wards. We have a special facility where the students can see these patients. And this actually opens up huge opportunities. So let's take Deb's subject, which is rheumatology. Now, there are probably about a dozen things in rheumatology, a dozen conditions that a medical student really must see. And it's a bit by chance if they see those conditions when they attend ward rounds and go to clinics. So if you've got a group of, say, 30 or 40 patients with rheumatological conditions, you could get those patients to come in to your hospital or to your medical college, and the students could see them. And this is a brilliant way that saves time and effort, and it guarantees that the patients that you want your students to see are seen by your students.
Google Form.
So don't get them to examine you. Invent new ways of doing it. Don't get them to examine their relations, their parents, their sisters, their uncles, their aunts. That's not a good idea either. Legally, it's a minefield. Don't go there.
Thank you a lot. Thank you a lot. Dr. Khalid, I think time for you, for any one of our students want to ask.
We want to hear the students.
Yes. Yes.
I make a couple of students as a panelist. They could just open the microphone and ask a question directly to Professor Nigel. So, anyone ready?
Can I go ahead and ask a question?
Yes, Ali?
Yeah.
Thank you. So, my name's Ali. I'm from Wasit University. First of all, I would like to express my happiness to finally meet you. And unfortunately, it's virtual, but
it'll change. It'll change.
Hopefully. Yeah. So I was waiting for this webinar so long, and I hope that the next one will be very soon because I can't wait for it.
Give us a few days.
So I'm a fourth-year medical student, and I'm a national officer on medical education in IFMC, that stands for International Federation for Medical Students Association.
IFMA. Yep.
Yeah. So I just had a session with my participant discussing curriculum development, and I decided to bring my participants here to listen to you, and I think they all liked it. And we were discussing how students can be involved in decision making regarding curriculum and extra. I liked how you described that there is a massive change in medical education regarding the current situation. So my question to you, like in your opinion and your experience, how we can make students involved meaningfully in the upcoming period, because there will be a lot of decisions to be taken for changing the medical education to be appropriate with the COVID-19 situation. So the question again is how to be meaningfully involved.
Well, one of the things that impresses us enormously is that in many of the medical colleges in Iraq, there are people who are leading those colleges who have great vision and great hope for the future. They understand the huge importance of the views and opinions and contributions of medical students. And we sense that in many medical colleges, the people who lead those colleges, the deans, the deputy deans, are looking to develop a collaboration with students. And this is really so important. You are the future colleagues of your teachers. And it's really great when you see teachers treating their students like future collaborators and like colleagues. One of the things that works extraordinarily well is to have student representation on every single college committee, with the exception possibly of an assessment committee. You don't want the students having the questions to the exams in advance. But every other committee, student representation is desperately important. We've been so impressed by the huge ability of the Iraqi medical students that we've met. Wherever we go, we've been up in Erbil, we've been in Baghdad a lot, in Kerbala, down in Basra, but wherever we go, we see massive ability in the students. And somehow, if that ability can be translated into thinking really positively together with the teachers, you will transform Iraqi medicine. And that collaboration has to occur. It's so important. When we refined our curriculum in Sheffield and we had a huge change in 2003, 2004, which seems light years away to some of you, the one thing that we did was to make sure that the students were involved right from the start. And the students were contributing, and they were brilliant, absolutely brilliant. And I would never, ever make any change in any medical college of significance as regards medical education without student involvement. Student involvement is absolutely essential. But this, of course, requires students to behave in a professional manner. This requires them to be professionals, like little mini doctors, almost from day one, year one. And this is why we think also it's really important that year one students actually understand medicine right from the start. This is why early clinical exposure and engagement is so important. For example, I remember 20 or so years ago walking along a street with some medical students, and they were all first-year medical students. Someone fell over and was injured, and immediately they said, "Are you doctors?" And they said, "No, we're medical students." And the person asking the question said, "Well, that doesn't matter. That means you're almost a doctor." And this poor person was bleeding profusely, and none of the medical students knew what to do. So we had a discussion, and we thought, okay, what we have to do is the day students arrive in a medical college, we have to teach them enough about what we would call street medicine so that they can stop someone who is bleeding, look after someone who's collapsed and might be fitting, and undertake cardiopulmonary resuscitation. So the first 3 skills that they learn before they go to any lectures are those. Because actually, that's what's expected of them on the street. I'm a medical student, but I can't do anything. That doesn't sound right. So good luck, Ali. I think that if you can get your college to get your engagement and your collaboration, it'll be brilliant.
Thank you very much. I like your answer. I'm very satisfied with it. Thank you.
Thank you, Professor Nigel. I think Dr. Karim raise hand. You have the way for ask Professor Nigel, please. Dr. Karim.
Yes.
Welcome, Dr.
Yes.
Karim.
You can hear me?
Yes, Dr. Karim, we've got you.
Okay. Okay. What are the percentage of student failure indicated there is a failure of program or a failure of teachers?
That's a very interesting question. Thank you.
Second question.
Let's answer the first one.
Okay.
Let's deal with that. This is a big one. This is a very big one.
Yes.
If in any year there is a failure rate of greater than about 10%.
10%, yes.
If there's a failure rate of greater than 10%, there is either a problem with the examination or there is a problem with the teaching. It's not a problem with the students. Now, we know that the failure rate in some colleges can be as high as 60% in some examinations. That doesn't mean the students are bad. What it does mean is that either the teaching isn't quite working or the assessment isn't working properly. So we work on the basis that if there is a greater than 10% failure rate, something has gone wrong with what we're doing. Now, ideally, the failure rate should be 0, because if you choose your medical students carefully, you won't have people who are unable to complete the course. But the problem I think that you might have is that at the moment you're admitting people to Iraqi medical colleges only on the basis of the high school examination mark. And that actually doesn't predict how they're going to perform as either medical students, and particularly it doesn't predict how they're going to perform as doctors. Now, Deborah's just said, or want to. I mean, what was fascinating, we asked this question in one medical college, and we won't tell you which college it was, but we said, how many of you actually want to do medicine? and only about 70% put their hand up. There were a large number of people who just ended up doing medicine for reasons that were not particularly clear, but they weren't related to actually wanting to try and help people or care for people. So sometimes people get ill, and if a person begins to perform badly or poorly at medical college, what we would do, the first thing we look for is, are they well? Are they ill? Let me ask you a question, if I may. What percentage of your students have a psychiatric problem at some stage during their time at medical school? Mental health problem. Are you still with us, sir? Hello? Is anybody
Yes,
there?
yes. Yes, I hear you. Yeah.
Karim.
Yes.
Dr. Karim, the question we were asking is, what percentage of your students in your college have a mental health problem at some stage during their time with you?
There are three students, some problem with mental health, yani just fear or just obsessive, and can pass it.
Well,
And,
the literature...
but the time with their student is open. As he need, how much need time, open.
Well, what we've found, we did a big presentation in Norway some years ago about this because we were concerned that we weren't picking up students who had mental health problems. And we had about 100 people who came to this meeting. And from data from around Europe and also from Canada and the US, it's about 25% of students will have a mental health problem at some stage during...
This is due to drug abuse. Due to drug abuse.
No.
Not due to mental health.
No, it's nothing to do with drug abuse. It's actually depression, anxiety. Some people have a psychosis.
And this is a big question. This depression from drug abuse or drug abuse from depression?
No. It's nothing to do with drug abuse. It's not related to drug abuse. I don't know the data for Iraq, but the data I'm giving you now are data which are not related to drug abuse. It's not drug abuse. This is people who just get depressed, they get anxious, they get obsessional, whatever it is, but it disturbs the way they learn. Often these are self-limiting. I have another question, if I may. What percentage of your students do you think have a psychopathic tendency? Or like you might call it sociopathic tendency?
Yes.
Dr. Nigel, I can negotiate only or interrupted your conversations. The problem with us, really, the psychiatric elements, whether for the patient or for the student, we have some little bit missing. Really missing.
Yeah.
Many of us as a teachers and as a responsible for the college, they deal with such conditions like anxieties, like some element of minor depressions, and we manage them individually without a specialty. So we can get much little bit fixed data for that. Really, there is a much, because when I am responsible for the college and I am responsible for many numbers of students, I think there's many students exposed for a lot of psychiatric impact from the situations, from the way of teaching, so from the whatever the field of study of medicine. So there is many, really 20%, 30%, I can suggest such a number.
We got very anxious about this because we were finding students who were failing or just beginning not to perform as well as they should. And often the problem was health. It was a health problem. It wasn't drugs. We have very few problems with drugs. Every place has some problems with drugs, but I think on the whole it's pretty small. But what we were concerned about was we didn't want to miss someone who had a condition that needed help, because we have a duty of care to the students. There's one example I can give you of a young girl, a young woman who was a very clever student who suddenly started not to perform very well. She wouldn't turn up, didn't seem to be engaging. She failed an exam, and she turned out to have a meningioma. She turned out to have a brain tumor. So, in fact, a great colleague of ours, as a medical student, was admitted to a psychiatric hospital years and years ago, and he turned out to have a brain abscess. So it's really important that someone's looking after the physical and mental health of the students. And whenever you see a failing student, someone who's been performing very well, and suddenly not performing, that should raise concerns and raise suspicions.
Dr. Khalid, would you please open the mic to our student? Maybe they want to ask some question.
How can we get it so that you can see us? We'd love to be able to see you all.
Yeah, we'd like to hear from our students. Dr. Khalid, would you please?
I already make some of them as a panelist.
Hello, Doctor.
Yeah,
can anyone hear me?
Rami, yeah, yes, please.
Okay. So, hello, Dr. Nigel. Hello, Dr. Deborah. We are very happy
hello.
to see you.
Yeah. Hi there.
And thanks to Dr. Hussam and Dr. Nasir, Dr. Khalid for this nice, organizing this nice webinar. Okay, it was a quite amazing webinar and nice information with your infos. I have 4 questions to discuss with you.
4? Okay, go ahead, Rami.
Okay, so first one about selection of med students. Okay, so you said there should be pre-med school, okay, assessments or exams. So about Iraq, you have the information that we just depend on the degrees of schools, degree of in schools, okay, to select students for to enter medicine or medical college. So about developing a system like the one you have in UK and other worlds. So how does it take, or how long can it take to develop a standard rules in Iraq to or curriculum or exams, okay, to select students in a very professional way, not just depending on their degrees? So how did UK took time to reach this this how I say the standard rules that you have now?
Rami, that's a very good question. It came about slowly, and the reason it came about slowly was because it is evidence-based. And what happened was that an old friend of ours who went and worked in Sydney in Australia, he was one of the people who did a lot of work to work out how best to try and select students. And it took him about 2 or 3 years of research to come up with this idea of the multiple mini interview. And then it was put to the test and people started using it. And it took, I suppose, about 5 or 6 years before people realized that we needed to have some really reliable way of trying to select people to come into medicine on the basis of the behaviors and values that we thought doctors ought to have. And this was all because we know leopards don't change their spots, and what you're like at 18 is probably going to be what you're pretty much like for the rest of your life in terms of your behaviors and your values and so on. But to actually get it to work within a college would probably take no more than a year. You could change the way that you select people pretty much overnight, but it would take about a year to get it embedded in a college. So it doesn't take long to actually make it happen, but it took quite a long while to make sure that it was the right thing to happen. So a lot of medical colleges now around the world are using this approach of, is someone reliable? Are they honest? Can they think? Can they make deductions? Do they understand what risk is? Are they honest? And these actually have now been shown to relate to performance later on in medical colleges. So there's some work by a guy called Eva, who's a Canadian, and he has shown that if you get the right selection at the beginning, those people will continue to do well throughout the time they're at medical school and also in postgraduate examinations. So there's something about how you select which is really important. And this is desperately important for you in Iraq, because what is it, 40, 50% of interns give up. They disappear.
Yeah, that's right.
So why is that? It can't just be that Iraq's a difficult place to work in. It must be something to do with people not being selected properly in the first place.
So many UK medical schools or colleges also actually have students interviewing prospective medical students, because they're the ones who actually know what the course is about, but also they know the values and the attributes of colleagues that they want to have joining them. And from the teacher's point of view, I think maybe we just need to remind ourselves that these medical students are going to be looking after us when we're old and decrepit and falling apart. So we need to get the right medical students in the first place.
Yeah, that's right. Thanks for the answer. So I hope it doesn't take too long to develop this or to reach how UK choose med students. Okay, so the second question is about you said about that case where the patient presented with pneumonia and sputum. Okay, so you said that the patient should know first the diagnosis. Okay, not the husband. So I think there may be a situation where the wife, she cannot tolerate to hear this bad news. So do you think it is better to tell the husband first?
No, absolutely not.
No.
I don't believe that this is cultural. I believe
like that.
Well, okay. Let us hope you don't personally get ill, Rami. Let's hope that happens.
Thanks.
But just say that you did become ill. Who do you want to hear first? You or somebody else?
Well, me, but
okay.
Okay.
Yeah. But actually, that is what most people will say. So
even women.
Yeah. We're both retired from medicine now. We're terribly old. We're very old, ancient, decrepit. But the first question I would ask any patient who came in to see me in my clinic would be, would you like me to tell you everything that I find out about you? And you know, in 20 years or more of running a sort of cancer type clinic, not one patient said no. Not one.
So they all need to hear the diagnosis first.
Of course. And that requires the person who's telling them to be very, very well trained in communication, breaking bad news. How do you do it? You can't learn that overnight. You don't learn it out of a book. That's why you need good role models who can teach you how to do it. And you'll see how, when it's done properly, it works very well. But I can't think of any situation, provided the patient is able to understand and hear and understand what you're saying, that the patient is not the person to tell. It has to be the person that you tell. It's them. This is all about autonomy. They have the right to know. No one else has the right.
And this is why I think our College of Medicine in Wasit. So now focusing on breaking bad news more and more, I think this is more important than all day.
I think it's really difficult. I mean,
yeah, it depends on training and not something you can read. Okay.
Did you say are you from Wasit?
Yeah, I'm from Wasit. I'm studying Wasit University.
Yeah, great.
Yeah.
Good place.
Yes,
we'll come and see you one day. We'll come and see you.
Of course, we will be happy to see you there. So my last two questions about the tutors and about something that you said about the the graduation of med students. Okay.
Yeah.
So the first about tutors. So now at crisis because of COVID-19. Okay. So we see that we need to make a more stable and standard rules of medical education under crisis or crisis period. So what do you think that if there is some conference that need to put rules and develop tools or new tools to replace the how to say that the problem of clinical teaching and something we see now that there is a lot of apps on Android or other mobile phones that have clinical scenarios and even videos of real patients that they present. So why there shouldn't be something standard that all med schools can have access to it and maybe utilize the info that it does present in under crisis like COVID-19 and other crises in the future maybe.
Yeah. Well, I think that's a great suggestion, but and you're right, there's lots of websites which show real people giving bits of their history and even examination. And there are a huge number of publications which talk about how you can conduct a physical examination at a distance from a patient. And there's a colleague of Deb's in the States, a rheumatologist, who does 60% of his consultations now through telemedicine. And he gets the patients to examine themselves and he can see what the problems with the joints are. I mean, you can see my hand at the moment, and you could probably, by looking at my hand, if I had osteoarthritis or rheumatoid arthritis or gout, you could make a diagnosis just by looking at my hand. And there are many specialties which telemedicine lends itself to extremely well. Dermatology is another one. But actually, this is why we stressed history taking, because the majority of diagnoses are made from the history. And what actually is a history? Well, a history is, at its fundamentals, a patient telling you about abnormal anatomy, abnormal biochemistry, abnormal physiology, possibly abnormal genetics. And that's it. There's nothing more to it. But that takes about 15 years of practice to get right. It's a really difficult thing to do. So the sooner you can introduce history taking to students, the better. That's why year one students need to start to learn how to take histories, but learning alongside the anatomy, the physiology, the biochemistry. It fits together.
It is an integrated system, as you say.
Absolutely. Absolutely. I mean, there cannot be any other better way to teach medicine and to learn it.
And this is the new model that we are learning, using it now. And
you are using it in Wasit.
Yeah.
And that's great. That's absolutely great.
So the last question.
Going back to your question, again, if I may, and that is, what do you need to do? Actually, you need to see patients. So by whatever means you can, you need to see patients. You need also to try and help, because you're in Iraq, you need to help Iraq. So if you can start to develop a telemedicine system, maybe amongst some of the colleges in southern Iraq, and you share some of the recordings, okay, there are legal issues and you need permissions and confidentiality and all that. But if you can start sharing these clinical experiences, you could build up a massive library of common conditions. And by probably within a year or 2 years, you will actually have a library of all the common medical and surgical and pediatric and obstetric and gynecological and psychiatric problems that you're ever likely to see as an intern. So it requires planning. You can't fix it quickly. You can get things off a shelf, but they won't always be suitable for you in Iraq. A classic example was a medical school that was established in the United Arab Emirates at a place called Sharjah. And the Sharjah Medical School bought the curriculum of the Melbourne Medical School in Australia. And after 2 years, they found it didn't work. So they had to build a new curriculum based upon the needs of the people of the UAE. It's very dangerous to assume that what's happening somewhere else in the world will necessarily fit for you. So develop your own system. And you talked about the future. Well, this is future proofing. This is actually developing the library that will allow you access to all this fantastic clinical material. But you've still got to get to the patients. So how are you going to do that? Well, what's happening is two things. One is, earlier today in the UK, it was announced that there is a 5-minute COVID test. This 5-minute test is being tested at the moment, but it'll become worldwide, we hope, within a few months. It means that you as students could be tested on a daily basis to see if you have COVID. And if you have COVID, you go home. If you don't have COVID, you go onto the wards. And you go onto wards that are COVID-free. And what is happening in the UK is that hospitals and parts of hospitals are being created which are COVID-free zones. They don't have COVID patients. They don't have staff looking after the patients who are looking after COVID patients as well. So there are things that can happen within a health service and at university level and in testing that will allow you to get to patients. Okay, it'll take a few months, but it won't take more than a year. So the future isn't completely bleak. The future is actually full of hope.
Thank God, I hope that too. And to get rid of this crisis as soon as possible.
Well, remember, about 100 years ago, the Spanish flu, which came through the world, particularly Europe at that time, it took 8 or 9 cycles of flu before it began to disappear. So we're now in our second peak of COVID. We've probably got another 6 or 7 to go.
I hope God. So my last question is about, you said that we need to develop, an intern that has standard information as other students from other province. Okay?
Yeah.
Okay. So how can we reach to this thing if we have different curriculum in different college, like we have studying Lister model as you have, okay, as you know. So how can we do the unification for all med college to reach this, to reach the intern that has the standard info so that the hospital can count on it?
Yeah.
Okay.
You've asked all the difficult questions, Ravi. They're very good questions. And this is probably the most important of the lot. How do you do it? Well, we suggested one thing, which was that you share questions in your final examinations across colleges. So that, let's take, you have to sit a paper in medicine, you have to sit a paper in surgery, obstetrics and gynecology and pediatrics. And in each of those subjects, there would be questions that would be the same in each college, regardless of the college. College would set some of its own questions, but let's say 25% of all the questions would be sat by all students in all medical colleges. That would give you a very good idea about the knowledge and understanding that students have within different colleges, and it would also tell you how well a college is performing in terms of its educational activities. So it's a way of quality assuring the college and quality assuring the students to make sure the students are at the right level. There is another thing that really is part of your question, and that is knowledge is just one part of it. The clinical skills are another part of it. And before you graduate in medicine, you won't have practiced any of your practical clinical skills on a real patient. So the first time you stick an intravenous cannula into something called a patient will be when you're an intern. So if we can make it, if the Ministry of Health in your country would agree, and if the Ministry of Higher Education, if we can get students more involved in actually providing care for patients and doing things for patients, it means that when you become an intern, you're actually better able to do the job. And it's not such a frightening step up. Deb has a little story about a doctor or a group of doctors that we saw not so long ago in Baghdad.
Yeah. So we were at a conference and we were approached by some students. Well, they were ex-students. They had graduated from Baghdad Medical College, but they were actually doing videos and making films. And we said, well, why aren't you doing medicine? And they said, well, during our time at medical college, we had wonderful teachers and they painted this wonderful picture of us being able to help patients. And it was going to be so great. And we were so happy. But when we became interns, we've discovered the real reality of being an intern. And life isn't like that at all. And we felt not only unhappy, but were very shocked by some of the practice that we saw. And so they decided that it was actually their responsibility to leave medicine altogether. And that was actually devastating for us to hear.
It was absolutely terrifying to hear that. That it was as though they hadn't been prepared to be an intern. So
this is quite a problem we have. Yeah, that's right.
So there are lots of ways that this can be fixed. Years ago, if a graduate from an Iraqi medical school applied for a job as a junior doctor in the United Kingdom, almost always they would be given the job without an interview, because it was known that the quality of the doctors from Iraq was so high. It matched anywhere in the world. And that's what we would love to try and help you get back to that position. Because you're very, very clever people. I mean, you're brilliant in science, in medicine, astronomy, mathematics. My goodness, you gave the world so much. You know, the brain power you've got is enormous.
Thanks a lot for this comment. Yeah, but the problem we have now that even if we had a good medical teaching, medical education with the clinical good clinical background, the problem that the hospital and anything rules in the hospital that does not provide the good atmosphere, okay, to apply what we took in med school on the patient. Like if the patient with pulmonary embolism, so it's it need an angiograph, okay. Yep. So CT angio, it is difficult to have it in every hospital in Iraq, okay. And as the book say, it is the first line investigation, okay. So this is the problem we are trying to deal now, because the patients, okay, they think that the fault from us, not from the hospital or not from the government. Okay, this is the problem we are facing now.
We understand. We understand the difficulty.
So about the intern, okay, you said, so is it good to make a special medical consult that supervise on all med schools, okay, and to see the results of med students and the quality of education in every year, so that the intern or the graduated med students, this medical consult is very sure that these interns are qualified, or not 100%, but let's say 90%.
Well, your suggestion is a very good one. If you look around the world, the regulation of medical education is best in countries where there is a group of people, like a medical council, that is completely independent of anything political. So in Canada, America, virtually every European country, Australia, New Zealand, South Africa, all of these countries have a group that will look at what is happening in medical schools and in intern training and in postgraduate training. They look at the whole lot together. And they're not trying to be nasty. They're trying to lift standards. They're trying to make everyone work better and the whole system work better. But it isn't connected to anything political. It's completely independent of any political influence. So that works well. It really does work well. And it means that there is continuity of an approach. So it doesn't change when a government changes. It is always there. It's a constant throughout 20, 30 years. And this is called, Deb said, it's self-regulation. What is the definition of a professional or a profession? Medicine is a profession, and a profession is something that regulates itself. It doesn't get regulated by other people. So good luck. It would be great.
Yes, this is good. So thanks again for answering all my question. I agree that's been very long and took a long time, and you are very tired. But it is very pleasure to see you again. And thanks again for you, Dr. Nigel and Dr. Deborah.
Well, I'm staggered that we've still got about 300 participants. And to all of you, we say thank you for staying with us. And you're remarkable people.
And also, I thank my colleagues that heard me and beard me. Okay, so thanks again to Dr. Hussam, Dr. Nasir, and Dr. Khaled for providing this opportunity to us. Thanks again, and hope to see you again in our college.
We look forward.
Okay, thanks. Goodbye.
Nigel, do you have time for other questions? Or?
Yep, we certainly do. Yep.
Hello.
Thank you very much.
Hello. I'm Dr. Karim in Howler Medical University.
Oh, hello there.
Hello. Thank you, Dr. Najil, and thank you, Dr. Deborah. I have a comment and question. My comment is about, do you know WHO have classified the health services staff to 3 levels: physician, nurses, and health professional. Yeah. We must not forget the role of the nurse practitioner who have PhD or diploma or MSc degree, for example, surgical nurse practitioner, pediatric nurse practitioner, and other. Yep. And other specialties. So nurse practitioner is a global academic program in nursing, and they have some independent medical intervention, especially nowadays during COVID-19. What is your opinion? This is a comment number 1. Number 2, I think there are some characteristics of the good physician should be included. For example, professionalism and scholar approach and medical technology, for example, robotic system in diagnosing the disease, and also teamwork and self-learning. And my question is about simulation. Do you think that simulation method in the teaching we are in the university replace the clinical practice in hospital nowadays in COVID-19? Thank you so much.
That's about 72 questions, I think, but thank you.
Thank you very much. Thank you.
Okay, take simulation. No, simulation will not replace clinical teaching and clinical experience. We do not treat dummies. We treat people, and we care for people. We do not care for dummies. You can learn from working with dummies, and in simulation, you can make yourself safer to a particular procedure by working with models and dummies, but you can't do medicine except on real people. So you do need real people. You can't learn medicine in simulation laboratories. Yes. It's just a bit of a help. going back to your first point about the WHO classification of people, I don't think that's a particularly helpful classification, because medicine is expanding so fast and the WHO is not keeping up with the expansion of people within medicine. So, for example, where would the WHO, or where would you place someone who's called a physician associate? I don't know whether you have physician associates in Kurdistan, do you?
Yeah, in Kurdistan, yeah.
You have physician associates?
Yeah, in Kurdistan, yeah.
So what do these people do?
Nurse practitioner is a global, I think, for example...
No. It's not a nurse practitioner. It's a physician associate.
Yeah.
That's a very specific term.
Yes, physician assistant. Also, there is another title, academic title. They have diploma. Also, the assistant physician. But I mean the academic nurse who hold the PhD or MSc in nursing. So they call nurse practitioner. Maybe they have some independent intervention. It is global program. You know, all over the world they working independently sometime. Yes.
Yeah, we have those too. We have nurse consultants and nurse specialists.
Yeah.
And I think you find those all around the world. We don't expect them to have an MSc. We don't expect them to have a PhD, because having a PhD or an MSc doesn't actually mean that they can do the job. It just means that they've studied or done a piece of research, which again doesn't link to them being able to do the job. The best ultrasound endoscopist that we had and I used to work with was not a gastroenterologist, but was actually a nurse practitioner. And she was brilliant. And the reason she was brilliant was because she was doing 8 to 10 patients a day, looking for 2 to 3 millimeter tumors in the small bowel and finding them when the gastroenterologists were doing maybe 1 or 2 a week and missing them. So she was absolutely perfect. She didn't do anything else. But a physician associate is someone who is actually trained to do virtually everything that an intern is trained to do, but they stay at that level. They may specialize, become respiratory or cardiovascular or whatever. They don't take as long to train as a doctor. They take 3 years. They have a basic science degree in the first place, and they come in to do this 3-year course, and they learn the basics of clinical medicine. And these people are very commonly found in the States. You find them now all over the UK, beginning to find them in Europe. There are huge advantages in having this sort of person, because they increase the number of people who are delivering healthcare, but they're very talented people, very able, and they increase the number of doctors or doctor-like people enormously. And one suggestion that we would make, if I was the Minister of Health, would be, why not look at developing physician associates? Because these people would actually do the jobs that interns do, and they would stay as interns. They would be permanently there. The interns,
especially in primary health care, yeah.
No, they work in hospitals. They work mainly in acute medicine, acute surgery, acute obstetrics and gynecology, and pediatrics and psychiatry. That's where they work. They don't work in primary care.
Yes.
It's a very different approach.
Sometimes working in primary care, yes. In our
region. No, these people don't work in primary care. You need doctors in primary care. Some years ago, Deb and I were asked to help create a new medical school in Australia at a place called Wollongong, which is about 70, 80 kilometers south of Sydney. And that college of medicine had one purpose, and that was to produce doctors who would end up working in the rural communities of Australia, sometimes hundreds of miles away from any other healthcare facility. And that opened some years ago, and it is absolutely brilliant. It's so successful. These people are outstandingly good doctors. They really are excellent. The one thing that we did in this college that no other college in Australia was doing at the time, although others have copied it, is that the students in one of the clinical years would leave the hospital where they were based, they would leave the medical college, and they moved into the community. And they spent a year working in the community, in health centres. 6 months in one, 6 months in another. And they learnt medicine because they were doing it. They were learning by doing. They became clinically responsible people. And it was a brilliant success.
But doctor, I think if you go to the net, when you write nurse practitioner role, there are so many roles more than physician assistant. If you go to the net, because it is a global program, nurse practitioner, nowadays focusing on the subspecialty. For example, pediatric nurse practitioner, surgical nurse practitioner, and so on. I think it is very important, so important because physician assistant 2 years, the study of them 2 years, but the study of the health science college or nursing college maybe 5 years or 4 years graduated, and after that they enter the course of the nurse practitioner in the pediatric or in the surgical and so on. So I think they are so many clever to health services in the primary health care or on the hospital also. This is my opinion. I am also agree with you about physician assistant in the.
We need them all. We need them all. Of course, we need nurse practitioners, nurse specialists. Absolutely, we need them. But I think also, and we've met many physician associates, they're different from nurse practitioners. Nurse practitioners, on the whole, do one job. They do one thing in one area of medicine.
That's right.
The physician associates actually are generalists who function like interns or senior house officers or even junior registrars. They function very much like doctors in a general way. So they see undifferentiated patients.
Okay, anyhow, thank you.
Pleasure.
Thank you.
Another question for professionalism and medical technology. You are not understand me.
Yeah, I didn't understand the question.
Yeah, medical technology, it means characteristics of the clever or successful physician should have knowledge about medical technology, robotic system in diagnosis and treatment, and also teamwork, self-learning, scholarship or scholar approach in teamwork. I think it is very important to success the good physician.
No, I agree. I absolutely agree. So how are you going to assess teamwork in your medical students?
Yes. In any work, you have maybe you organize teamwork. For example, you have surgical process. Maybe you need for example anesthesia and another human resources sharing with you to achieve the procedure. Teamwork is very important, I think, in the medical.
So I absolutely 100% agree with you. You're right. So how do you assess teamwork? Well, you've got to make the student part of the team. So you build students into the team that's delivering healthcare. They aren't there as observers. They're there as participants. And technology, well, medical technology, what sort of technology are you thinking about?
For example, robotic system, for example.
Oh, no. You don't need an intern to understand robotics.
I mean medical technology for robotic system, for example, remove stone, remove and something like that.
Yeah, but you don't need medical students to understand that, or even interns to understand that.
No, I mean physician.
Oh, but that's not. We're talking about students. We're talking about medical students, undergraduate medical students. They don't need to understand anything about robotics.
Okay.
You'd be wasting time teaching about robotics. You could be doing other things which were far more valuable.
Okay, well, thank you, Dr. Karim, for valuable questions. I'm not sure if you have a time to take maybe last student or...
Okay, well, have a student.
Okay. Any student available?
Hello, Doctor.
Zaid.
The last one. Yes.
Hello, Doctor. My name is Zaid. I'm a 2020 graduate. I'm soon to be an intern. And thank you very much for your more than beneficial lecture. And I'm not taking too long. Less than 72 questions at least.
Oh, why not go to 100?
I will try next time. Doctor, the one single question I have, which you have partially discussed, and I was hoping for more detailed answer, is I'm going to be an intern soon. How do I face the psychological aspects that are facing the interns nowadays, like exhaustion, stress, fear of infection, fear for family, how to cope with social and professional life in the meantime of COVID? I mean, not in a way to, not meaning to consult a psychiatrist, but just how to cope with it. And how do you do this in UK, the optimal way?
Well, I'm not sure we have the optimal way. We have some good things I think we do, and we're learning all the time. But thank you for your question. It's a very, very important one, because you as an intern are so important to the patients and to the country. And protecting you and looking after you is absolutely critically important, because Iraq cannot afford to lose your services. It needs you healthy, supported, content, as happy as you can be, not threatened, not fearful, not feeling that you're in danger. Because if you feel any of those, you won't be able to perform in medicine as well as your patients and as well as you would like. So we think that the interns actually need a lot of support. How that can be delivered is something that we need perhaps to discuss on another occasion. But every intern would need to have someone to whom they can go and talk about all the things that you have mentioned and get guidance and support, real support, to see them through what is a really difficult time in medicine. The transition from being a student to a doctor is a big jump, very big jump. And there are some real challenges that we know of in Iraq. So maybe the 8 colleges in southern Iraq can get their heads together, students and the faculty, and work out what it is that needs to happen to support the interns. We know that at the moment there is no curriculum for interns in Iraq. There's no training program for interns. So that would be a good starting point. And as part of the training program for interns, there would be built in all the things that you've mentioned: support, psychological support, emotional, health support. Because if you go to work and you're ill, you're not actually any good to the patients. So you've raised a really important point, which we can't answer really in this webinar. It's too big an issue. So why don't you begin to come together and form, if you like, an alliance across the colleges, which starts to look at these really important issues? You're not alone in the world. Other countries have...
Doctor, thank you.
Very simple.
I mean, we've been taught throughout 6 years of medicine that if you need to provide the best care for your patients, you need to be the best doctor in physical and mental aspects. So my question is, what if the health, aside from health issues, the mental aspects also matters for a doctor. So if we can raise this, as in Iraq we don't have such mental caring, as to say, for physicians or for interns, especially newly graduates or interns. So I would like to have your suggestion if starting an association or an organization that care for the mental health of students that are soon to be interns or newly graduated interns will be a good idea and a good point to start.
I think, well, we wish you well and good luck with that, but it would be really good to try and build that into something which is a bit bigger, which is all to do with how you train interns, how you make them better doctors, how you give them the experiences clinically that they need to develop, how you make sure that they are progressing, how you make sure that at maybe the end of the first year of being an intern, people have some sort of opportunity to discuss with an educational supervisor, a mentor, how they're getting on, what's happening. There are ways of addressing these problems. Another way is to actually get your final year students in medical college doing attachments which are not just watching clinical medicine, but are doing clinical medicine. So they really begin to understand what it is like and what it feels like to be a doctor. Now, we've had discussions with many people up in Erbil and all throughout Basra, Baghdad, Kerbala, everywhere, about this issue. And the more you can get students to actually do things with patients so that they are beginning to function like doctors before they graduate, the better. So we wish you well with it and hope to see great things. So thank you for your question.
Thank you, Doctor. Sorry for taking your time, your precious time.
Your time is more precious. You are the precious one. What
Thank
we
you,
want
Doctor.
to do,
Sorry for disturbance.
No apologies needed. There's only one thing that motivates Deb and me, and that is we want to retire.
Yeah,
because
would be good.
when that would mean that the people who we've helped learn a bit, we've taught, are better than we are. So we want to become useless. We want to become no use to anybody because you will be better.
Thank you, Doctor. Hopefully no one will be useless. You are the resources for future products. Thank you.
Well, good luck to you, Zaid.
Thank you very much, Zaid. Thank you very much. Then I think it's a weekend, so, and we take your time. Maybe you plan to make outside or something like that. And I see it's a sunny day because the sun is on your faces, isn't it?
Yeah, the sun's just disappeared.
No, sorry about that. It's not every day the sun is shining in UK. I know.
Yeah,
you still have, I think, 1 hour or something like that to go out and walking and doing something in this sunshine. I don't know. Maybe.
Yeah, we do.
So thank you very much for your time, your efforts, and sharing these important knowledge with our student. And also thank you for our student for participant asking questions and being clever to asking these important questions and have an answer from you. That's I think good opportunity for them and all of the also the teachers also. So we are now at the end of the session. If you have any additional notes or something like that.
Well, it's just to say thank you very much. We're very we're delighted to see you, to be with you, to learn from you. Your students are wonderful. Universities would not exist without students. The most important people in universities are students because they will tell us the future. They will show us the future. And we have to give them every tool to allow them to do that. I think that's one of the functions of a university. It's to make us redundant so that our followers, the people who follow us, are actually better than we are. And listening to your students, they're pretty good. They're going to do very well. You're so lucky to have them in Iraq, and we wish them all great success.
Thank you.
Thank you very much for letting us join you. It's been a real privilege.
Thank you,
Dr.
Thank you, Dr. Deborah.
Bye to you.
And our colleagues in different college of Iraq and our students. We are very grateful from your effort, and we are grateful from your important, really important time we spent together. And we hope we're waiting for another special time like that. Okay. Thank you.
Okay.
Thank you.
Okay.
Okay.
Our pleasure.
Dr. Khalid.
Yes.
I would like to say very many thanks for such a highly distinguished webinar. Today we reached almost about 457 participants, and till now more than the half of this number are with us. So this means that it's very successful webinar. Nigel, please let me say you taught us, you learned us today, you provided us with many important knowledge today. But the most important and crucial thing is that you inspired us. You inspired our students, and I'm sure your words will stuck in their minds forever. Everywhere when I'm telling, when I'm in the classroom or with my colleagues, I tell them that Nigel is the best professor that I had ever I saw. So let me say from the bottom of my heart, I would say thank you, Nigel, and thank you, Deborah. Hopefully, we can see you physically, you and Deborah in Wasit University, when we would receive our lovely students again in the classroom. So I would say also thank you for all our lovely students who show this enthusiasm to attend this webinar to improve the future of the medical education in Iraq and the medical care for our patients. Thank you for all the attendance, and God blesses Nigel and Deborah. And thank you.
Thank you very much, and good luck to you all. Well done.
Yeah. Thank you. Thank you very much.
Bye-bye.
Bye.
Bye-bye.
Bye bye. Bye bye.